Hi, my name is Julio Franco, and I'm going to talk to about of Ticagrelor in patients with stable coronary disease and diabetes. Introduction: Ticagrelor is an antiplatelet medication that is used for prevention of arterial thrombosis. Stable coronary heart disease is due to poor circulation throughout the blood vessels in the heart. Diabetes is a chronic disease that appears when the pancreas does not produce enough insulin or when the body does not use the insulin it produced effectively. Coronary artery disease. Coronary artery disease is the narrowing or blockage of the coronary arteries, usually caused by arteriosclerosis. Stable coronary artery disease refers to a reversible supply-demand mismatch related to ischemia, a history of myocardial infarction, or the presence of plaque documented by catheterization or computed tomography angiography. Patients are considered stable if they are asymptomatic or their symptoms are controlled by medication or revascularization.
When a myocardial infarction strikes, the blood supply to the cardiac muscles is suddenly restricted. Starved for oxygen, these muscles begin to die, and within minutes are unable to keep the heart beating. The cause of this life-threatening attack is the obstruction of a coronary artery by a blood clot, resulting in most cases from atherosclerosis, which in the coronary artery is called coronary artery disease or CAD. In patients with CAD, atherosclerosis can begin to develop decades before symptoms arise. Since atherosclerotic plaques grow slowly. When a plaque ruptures and a blood clot forms, the threat of a vascular event becomes very real. Clots consist of activated platelets stabilized by fibrin strands. While activated platelets aggregate to seal the rupture site, fibrin formation is triggered by the coagulation cascade. An important part of this chain reaction involves factor Xa and prothrombin. When factor Xa encounters prothrombin, it cleaves prothrombin into thrombin. One molecule of factor Xa can catalyze the activation of 1,000 molecules of thrombin, which cleave fibrogen into fibrin. Fibrin then assembles into strands. Thrombin also leads to further platelet activation via PAR receptors located on platelets, thereby increasing platelet aggregation. This activation doesn't only happen in the blood flow, but occurs predominantly on the plaque surface. Because of thrombin's effects on platelets and fibrin, it offers a specific therapeutic target for the inhibition of arterial clot formation. Vascular protection through reduction of thrombin generation is a promising approach currently under investigation for the prevention of myocardial infarction, stroke, or cardiovascular death in patients with CAD.
Diabetes. Diabetes is a chronic health condition that affects how your body turns food into energy. With diabetes, your body doesn't make enough insulin or can use it as well as it should. When there isn't enough insulin or cells stop responding to insulin, too much blood sugar stays in your bloodstream. So, over time, that can cause serious health problems, such as a heart disease, vision loss, and kidney disease. Applications in medicine. The utility of ticagrelor in clinical settings is associated with high platelet reactivity, such as ACSS, PCI, and stent thrombosis. Co-administered with aspirin for the prevention of arterial thrombotic events in NATs with acute coronary syndromes or an history of myocardial infarction and high risk of developing an arterial thrombotic event. It's used in combination with aspirin to lower the risk of having a stroke or serious heart problems. Diabetic patients with coronary heart disease have a very high risk of having ischemic cardiovascular events. Part of this risk is explained by the increase in platelet aggregability, and therefore include aspirin treatment may not provide insufficient antithrombotic protection.
So the THEMIS trial is actually the largest trial of diabetes done to date. Over 19,000 patients randomized to either ticagrelor or placebo on top of low-dose aspirin. Specifically, these were patients with diabetes and stable chronic coronary artery disease. Patients with prior myocardial infarction or stroke were excluded. So these were patients who didn't have an indication for DAPT, who were randomized to ticagrelor or placebo and followed for a median of a little bit over 3.5 years. What we found in the primary composite endpoint of cardiovascular death, MI, or stroke was a significant 10% relative risk reduction. And we didn't really just stop there. There was, of course, an increase in major bleeding, as one would anticipate for a potent antiplatelet versus a placebo. But we wanted to see what patients within the overall large THEMIS trial might be the ones where we would rarely recommend use of either reinitiating or continuing aspirin, ticagrelor, or dual antiplatelet therapy in general. And what we found was that in the large pre-specified subgroup of patients with previous percutaneous coronary intervention, THEMIS PCI, there was a 15% relative risk reduction that was statistically significant, and a bleeding profile that was a bit better than in the patients without PCI. There was still an increase in major bleeding, but no increases in fatal bleeding or intracranial bleeding, or the most worrisome forms of bleeding. So really what we've concluded then from THEMIS, and in particular THEMIS PCI, is in that patient with diabetes with apparently stable chronic coronary artery disease, they are still at high risk for events like heart attack, stroke, amputation. The addition of ticagrelor to low-dose aspirin can reduce those events, but the physician does need to be careful to select patients that are at low bleeding risk. And in patients with a history of previous PCI, a good thing there is if they've got a stent, that means de facto they've been exposed to dual antiplatelet therapy before, presumably haven't bled, and if that's the case, that they're proven to be at low bleeding risk, those are the sorts of patients where initiation of ticagrelor and aspirin or continuation of current DAPT in that patient with diabetes might be considered.
I was wondering if you could discuss for a minute how you formulated this exploratory endpoint of sort of the catastrophic event that seemed like it was a patient-centered outcome, and what you found there in the overall population in the PCI subgroup, and sort of why you came to look at that endpoint and what it means.
Great question. So that was a pre-specified endpoint, and really the idea there was to look at all the ischemic endpoints that might matter to a patient, because of course people with diabetes are at risk for myocardial infarction, for ST segment elevation myocardial infarction, ischemic stroke, and we saw significant reductions in all those endpoints in the overall THEMIS trial. And amputation and acute limb.
Pros. Ticagrelor is a faster and more potent inhibitor. The benefits of ticagrelor is independent of the therapeutic strategy chosen, medical, invasive, or surgical. In selected patients with a history of myocardial infarction beyond the first year of DAPT, a reduced dose of ticagrelor seems to prevent atherothrombotic events, and pleiotropic effects may explain the results of the pivotal clinical trial and suggest a mortality benefit of the drug. Ticagrelor does not require biotransformation to be active. It has a significantly shorter daily of action. Cons. Discontinuation of ticagrelor will increase the risk of myocardial infarction, stent thrombosis, and death. There is no information about how it affects pregnant women or those who are giving lactancy. The drug has been associated with an elevation in uric acid and creatine concentrations. Ticagrelor therapy was associated with an increase in ventricular pulses. Dyspnea has been associated with ticagrelor therapy. Issue applied in Ecuador. The Plato study shows that treatment with ticagrelor, when compared with clopidogrel, reduced the incidence of death from vascular causes, myocardial infarction or stroke in patients with acute coronary syndromes. The benefits of Ticagrelor were obtained in patients with acute coronary syndromes with or without ST segment elevation, without increased rates of major blending, and were independent of the strategy following in the treatment of ACS, invasive or conservative. Here we can see a table where it shows the increase in the use of this medication in a period of 10 quarters. Ticagrelor and computer can see in this table.
THEMIS is a trial that compared ticagrelor to placebo in patients with diabetes and stable coronary artery disease. And in that large randomized trial in 19,000 patients, there was a significant 10% reduction in the primary outcome of CV death, MI, and stroke. Now, we hypothesized that the benefit-risk ratio of ticagrelor compared to placebo might be superior in patients with a history of PCI, largely because these patients have previously been exposed to dual antiplatelet therapy and presumably have tolerated it. So we did a pre-specified subgroup analysis of the THEMIS patients who had a prior history of PCI. That's a large subgroup representing 58% of the total cohort, approximately 10,000 patients, almost larger than many clinical trials in their own right. And what we found is two things. First of all, there was a greater benefit in that subgroup of ticagrelor with a 15% reduction in the primary outcome. The second observation is there was increased bleeding, somewhat to a lower extent than the overall trial, with a twofold increase in TB major bleeding, but there was absolutely no increase in fatal bleeding and no increase in intracranial hemorrhage, with statistically significant interactions. And the most important finding is that when we look at the net clinical benefit, the mathematical measure of the benefit-risk ratio in that population, there's a significant 15% net clinical benefit in patients with a prior history of PCI, which was statistically significant, whereas there was no benefit in patients without a history of PCI. And the interaction p-value for this is p equals 0.012. So we actually validated our hypothesis that there would be an interaction in terms of net clinical benefit between treatment effect and a history of PCI. So the conclusion is that for patients who have diabetes and a history of PCI, who are at high risk of ischemic event and low risk of bleeding, ticagrelor added to aspirin is a new treatment option to avoid severe major adverse cardiovascular events.
In conclusion, in patients with a stable coronary artery disease and diabetes without a history of myocardial infarction or stroke, those who received ticagrelor plus aspirin had a lower incidence of ischemic cardiovascular events, but a higher incidence of major blending than those who received placebo plus aspirin.